Chordoma today. I'm a medical oncologist with an interest in sarcoma and chordoma as a part of bone sarcomas. One thing probably to confess, because often when I see my chordoma patients, one of the questions I get asked is, have you seen this before and how many patients have you treated before? When I prepared for this talk, I actually went through my 10-year history of being an oncologist and found there was about 10 patients, which is a bit humbling to just be aware of how rare these consultations are. I mean, having said that, I still have seen more than the average oncologist in Australia, but just to put it in context, the breast oncologist sees that many patients in a day. So trying to actually get evidence and making sure that we getting the right evidence on how drugs are effective is not easy when we don't see patients very often. And one thing I learned earlier with treating chordoma is that often our patients will probably know about chordoma more than I do when I see them, because they've already had a diagnosis for several years and had the chance to focus on this topic. And there's certainly not a one-way conversation. It's more of a kind of partnership work and trying to make a decision what systemic therapy we should use. So just a little bit of background of chordoma, which I'm sure you know, it's an extremely rare tumor. Its incidence is 1 in a million. So that means in Australia there will be about 20 to 30 new cases, and only a minority would actually get to meet medical oncologists. Most of them are treated as surgeons or radiation oncologists, and only patients that have unresectable relapse or metastatic disease will actually get to see their medical oncologist. And in addition to that, just the lack of effectiveness of systemic therapy is another reason why not everybody will get a referral or consider systemic therapies. And as you know, there's no approved therapies for chordoma, not just in Australia but globally. So we'll go a little bit through what does it mean to actually have a approved drug and what kind of evidence we're looking for to actually be confident that we get good drugs for chordoma. So basically, this is what it takes to get the drug approved. So basically in Australia, the drug needs to be registered by the Therapies Good Administration. It's a regulatory body that approves drugs. And for any drugs to be registered, they need to have evidence of efficacy, of safety, and of quality of product that can be manufactured. So for this to happen, usually a sponsor has to apply, do the paperwork and pay the fees, and the drug gets registered, and then it has indication for the specific drug. This also then enables for drugs to be reimbursed and given PBS and for patients to get free access. So basically, this is the evidence that we look for to get the drugs registered. Essentially, we can still prescribe if the drugs are not registered, but this is what we talk about then when we call off-label prescribing. Off-label prescribing means that the drug does not have the specific indication for being prescribed, but the doctors that are prescribing it then basically need to do all the homework, need to make sure that there is sufficient evidence, make sure that they are aware of what risks there are, what side effects to expect. They need to have more comprehensive and in-detail discussion with the patients and make sure that they are aware that this drug is not routinely prescribed. In conditions like chordoma, it's a common practice because there's really nothing that we can prescribe on label. But it means that we don't have any regulatory body that's going to do all the work for us. And unfortunately, it also means that the funding is problematic because often the drugs have to be self-funded unless there's a compassionate supply or any other source of funding. So when we look at the levels of evidence in evidence-based medicine, the stratification is in 5 levels. So essentially, level 5 is the lowest level, and then as we go up to level 1, each next level trumps the one below. Level 5 is basically expert opinion. So if, say, myself and the Chordoma oncologist, in the absence of any solid data, think that something may work, maybe based on the lab data or maybe animal models, or just knowing how the drugs work and what the mechanism is. We can create a guideline, and that will be level 5 evidence. So it's very low, but at least kind of gives anyone who gets in the situation to prescribe some guidance what may work. Level 5 evidence is actually the most exciting one, because this is where the hypothesis, where the theories, a lot of the information that comes in the media about a new drug that is a breakthrough, it's a new cure, unfortunately, is level 5 or less, because usually it comes from something that's come in the lab, but very rarely moves to the actually clinical data, which are the higher levels. Level 4 and above are not that interesting. There's more clinical patient data which is used to confirm the theory. So level 4 is retrospective, usually cohorts, case series, case reports, so something that is actual information from the clinic, but it's usually done retrospective. So if I go and look at my 10 patients that I treated and put it as a series and publish what I think, what worked and what didn't work, that way gives some solid clinical guidance. But again, those are patients with different age groups, different stage of the disease, different previous treatments. There might be a lot of biases that can't be accounted for in that kind of research. Still better than just non-clinical data, but that'll be level 4. Moving on to level 3, that's usually prospective data. So that's then if I decide, okay, from this point on, I will recruit patients, and anyone who comes to my clinics, I will get the information about the demographics, about what treatment they had. I'll try to select patients that are a similar sort of stage and type of disease, and then I will record accurately data at the specific time points and get much cleaner information about what worked, when it worked, how profound the effect was, what the side effects were. Again, what's missing is the control arm, so we don't know whether it was my intervention or what else might have worked. So that will be level 3. Level 2 is a randomized control trial. So that's where we actually have prospective data, but we have 2 groups. We have one that's actually getting the intervention, the other one is getting the placebo, or the standard of care. So basically patients are randomized in 2 equivalent groups of the same age, same demographics, same stage. Everything needs to be balanced, and then just one has the intervention, the other one doesn't. And that's where we see if the intervention makes a difference and quantify that difference. So randomized control trial is the gold standard for evidence. This is what TGA requires for registration. And this is something that's very hard in rare cancers, because first, you need time. Second, you need number of patients. There's a rule of thumb, you need about 50 patients to get enough statistical power to prove the difference between 2 groups. And then if we say that there's only 30 patients per year, that means that there's a lot of time, a lot of resources, and a collaboration between multiple centers is required to actually get the level 2 evidence. It's not impossible, but it's quite difficult, and then it's disastrous when so much effort is put in and we get a negative study as well, so it needs to be really well planned in advance. Level 1 is the strongest evidence. It's not essential to get a registration. That basically requires multiple randomized control trials, which are put in a meta-analysis. There's also systematic reviews that basically proves, especially this conflicting data between multiple trials, to actually see what the extent of benefit is. That's probably something that we're hardly going to see in conditions like Chordoma. Just looking at the goals of systemic therapy, then, there's 2 settings that we use systemic therapy in. One is in early disease, in localized disease, so Chordomas that are amenable to surgery or definitive radiation treatment, using systemic therapy as an adjunct to surgery to reduce the risk of recurrence. Or in the locally advanced disease, where it's still not metastatic, but it's likely to be borderline resectable, than using it upfront to try to downsize the shrimp tumor to make the definitive treatment more effective. In metastatic disease, we don't expect to achieve cure. The goals of systemic therapy is to extend survival, to alleviate the symptoms, especially in chordoma, being in a location where that's usually pain, compression of the nerves or spinal cord, or bone fractures. And then we looked at those goals and tried to quantify them as objectives for the clinical trials. These are the terms that we use in clinical trials. So to extend survival, we talk about overall survival. That's and usually it's reported as a median overall survival, which is a time point when 50% of the patients are still alive. Keeping cancer from progressing, which is another essential goal in systemic therapy. The outcome is progression-free survival. Again, the median number of patients, over 50% of patients being free from progression. And then when we're looking at the potential of drug to cause tumor shrinkage, we talk about overall response rate. That's measured as a number of or percentage of patients that have at least 30% shrinkage on the treatment. And then we talk about safety and toxicity. We talk about toxicity rate that quantifies the number and the grade of side effects. And for the quality of life, there's quality of life scales which are used in prospective studies. Again, the patients fill the questionnaires every 3 months usually to report on the activities of daily living or other outcomes that can be measured for quality of life. Our arsenal for systemic therapy, we have 3 major classes of drugs. So the oldest one is the chemotherapy. Chemotherapy are the drugs that have been around the longest, that are cytotoxic drugs which affect all the cells in the body. They block off usually they interfere with the replication of the DNA by attaching to the DNA and causing breaks, or by essential proteins that are required for cell growth and division. The more metabolically active tumor and the faster growing tumor, the more likely they're going to be sensitive to chemotherapy. Chordoma, especially conventional chordoma, is another faster growing tumor, which makes it intrinsically resistant to chemotherapy, and is one of the main reasons why chemotherapy has been unsuccessful. The other reason is that the penetration in the chordoma is fairly low. Second generation of drugs are the targeted drugs. We heard a little bit about targeted drugs in the previous talks. So those are the medications that have been around for the last 20, 30 years, with the discovery of how the signal cascade work in the cell. Basically, cells are very responsive to the signals coming from the environment in terms of hormones or growth factors, which attach to the receptors on the cell surface. And then activate those enzymes, which then change their configuration and activate downstream protein inside the cell, and then it goes in a cascade until it gets to the nucleus where the DNA is altered, and then the DNA starts replicating and growing. This is a normal mechanism. It's very tightly controlled. As soon as the growth factor is out of the receptor, the system stops. But cancer cells can hijack the system either by overexpressing the number of receptors, just getting them all over the surface, or developing a mutation in one of the cascade, and then instead of those enzymes that get active and inactive, they're just constantly active. And they just continuously send a signal to the nucleus, regardless of what's happening outside. And then the last generation is immunotherapy. So those are the drugs that do not target the cancer cells directly, so they're not cytotoxic. What they do is they modulate the interaction between the immune cells and the cancer cells. Normally, cancer cells can be seen as abnormal by the immune system and attacked, but they do also express the receptors that makes them invisible to the immune system. These drugs block off that interaction and make the immune system overcome those defense mechanisms that cancers have. So in the only indication for chemotherapy is poorly differentiated chordoma. This is a subtype of chordoma, which is rare, 5 to 7% of all chordoma, so it's even more ultra rare. And it's usually diagnosed in pediatric population. It's a skull-based tumor which is more rapidly growing and aggressive, and as such is a bit more sensitive to chemotherapy. Again, being so rare, there's really no more than level 4 evidence of activity, but it's incorporated in guidelines, especially because these tumors are always at least locally advanced. So this is one indication where chemotherapy is only used, but it's one of the rare indications where the systemic therapies are indicated in non-advanced setting. One of the exceptions that we've seen with the chemotherapies is a drug called pemetrexed. Pemetrexed is a chemotherapy which is used in lung cancer, and it's a drug that actually inhibits one of the essential enzymes called thymidylate synthase. The drug is considered to be active in chordoma because the preclinical data found that about 80% of chordomas have deficiency of this enzyme already comparing to the normal cells. And this was the concept why this drug was tested and shown to have some activity in chordoma. Again, because chordomas do not allow chemotherapy to penetrate in the stroma that much, the dose is higher. So it's almost double the dose of pemetrexed that was used in lung cancer, and it showed some responses. You can see there on the graph on the top. 2 out of 14 patients, which is about 14%, had a response that was more than 30%. But if we look, basically the majority of patients had at least minor response. So all of them that had the tab going down from 0 had some response. Median progression survival was more than 10 months for this study. And then going to the targeted therapies, we get 2 types of targeted therapies. One are the monoclonal antibodies. Those are the big molecules, which you heard about in the previous talk as well. There's the drugs that are specifically designed to bind to the receptors on the surface of the cell. Being big molecules, they can't get inside the cell, so they can only attach to the outside the receptors. Also because they are composed of a lot of amino acids and in a specific chain that can't be given orally, so they're all given as intravenous infusions. They are more specific than the other class of targeted drugs because they only bind usually to the one receptor they are designed for. On the other side, we have small molecule tyrosine kinase inhibitors, so those are the smaller compounds which can get through the cell membrane and go inside the cell and block the enzymes inside, either the receptors, but from the inner side, or some of the enzymes down the cascade. These molecules can be given orally, but they are less specific than the monoclonal antibodies usually come with. They usually block multiple proteins, including the ones that are not intended, and they cause more side effects, what we call off-target toxicities. These are some of the potentially actionable targets in chordoma cells that we found in basic research. So the receptors for growth factors, like the epidermal growth factor receptor, vascular endothelial growth factor receptor, and platelet-derived factor receptor are some of the more common receptors that are targeted in multiple cancers. Chordoma specifically overexpresses EGFR, which is the epidermal growth factor receptor, and that was considered to be more attractive target. Then there was also intracellular proteins like CDKs, cyclin-dependent kinases, which promote cell cycle going from inactive to active dividing stage. And then, of course, the brachyury, which is the hallmark of the chordoma, which is a protein that's used to diagnose chordoma, which is expressed in the majority of chordoma cells and not in normal cells. This is a protein that is actually a transcription factor, so it alters how the DNA is expressed and how proteins are synthesized in the nucleus. And just being so specific for chordoma is a particularly attractive target. The problem with brachyury is it's hidden within the nucleus, so it's not expressed on the outside and it's hard to reach. That's why they haven't had any effective targeted therapies yet. These are some of the clinical trials that were reported in targeted drugs, which have indications and are registered in Australia as well for different cancer types. They were phase 2 studies, retrospective or prospective, so you can see the level of evidence. 3 means they were prospective, 4 is retrospective, and for various targeted therapies. So galectin, afatinib, EGFR inhibitors, rivastatinib and imatinib, more important, platelet-derived factor, and sorafenib and vascular endothelial. These drugs have all been looked at specifically in Chordoma, but it was single-arm studies, so the reported response rates were low, less than 10% in these studies. Progression-free survival was reported, as you can see in that 4th column, varying from 6 months to more than 12 months. But again, in the absence of control arm, it's hard to say how much of that is clinically meaningful. What is the expected progression-free survival for chordoma off treatment? Sometimes the disease can be stable for 6 months. Let's say that it's 3 months. Again, is 6 months really significant? They are prescribed commonly in the clinics based on this data, but it does come with toxicities, including the financial toxicity. Some of the drugs have been around for a while and they're off patent, and these are the costs in the last column. The bottom 2 are still on patent, and you can see that the costs monthly are usually prohibitive for standard use. And looking at this, are some of the EGFR targeted therapies which are used. So a lot of afatinib are tablets. Cetuximab is a monoclonal antibody. They come with significant skin toxicity because the epidermal growth factor is expressed in the skin as well, and managing these kind of side effects becomes really problematic. Quality of life is not great when someone has to be daily on these therapies. Apart from the acne-informed rashes and skin infections, patients can also develop quite bad nail bed infections, as well as diarrhea. So it often requires concurrent antibiotic use or dose reductions and dose interruptions. The PDGFR inhibitors cause also a lot of inflammation in hands and feet, causes what we call hand-foot syndrome. So again, it's always something that we have to balance. If there is a 3 to 6 months benefit, balancing that with the costs and the ongoing toxicity, whether it's worthwhile. So this is the brachyury, as I mentioned, and this is the stain for chordoma. You can see the brown is the nuclear staining of the brachyury, which is confirmatory for the diagnosis, and it just shows how much expression there is. You just need to have good targets for that specific protein. I'll go back to that in the immunotherapy section. So the immunotherapy are the drugs that target receptors, which we call checkpoints. Essentially, tumor cells, when they become cancerous, they start expressing proteins which are abnormal on their surface. And immunotherapy, immune cells can detect these molecules and can induce the immune response in destroying the cancer cells. However, cancer cells use one of the defense mechanisms by expressing these checkpoints, like PD-1, PD-2, which are programmed death receptors. They essentially give signal to the immune cells that they're not foreign, that they're part of the normal cells, and then the immune cell gets inhibited and moves on. Blocking those checkpoints with the monoclonal antibodies, which we call checkpoint inhibitors, blocks that interaction, and then the immune cells can act. The data, which you've seen from Prof. Thomas's talk as well, shows that immunotherapy can be effective. Again, the response rates are not high in the studies with pembrolizumab or tremelimumab, which are checkpoint inhibitors. The response rate are around 15 to 20%. But generally, these drugs are better tolerated than the targeted therapies, and they also usually the responses are longer for the patients that do respond. This is one of the immunotherapy studies, and it's interesting for more than one reason. It didn't use checkpoint inhibitors, it used cancer vaccine. against the brachyury. So that's the protein that we mentioned. And this was actually a randomized control trial in Chordoma, which is the only that I managed to find on the literature search that we actually have a proper phase 2 randomized control study, Chordoma specific. What the investigators did is they looked at the patients that had the radiation for advanced Chordoma, and they tested a brachyury vaccine, which was developed by genetically modified Saccharomyces fungi and adding the gene for brachyury in the genome, and then once they express it, they kill the fungi and then inject it as a vaccine to induce immune response in the patients with Chordoma. The study was designed that the patients were randomized in two groups. Everyone was getting radiation. They had to have at least one lesion irradiated and injected with this vaccine. And they would give 3 doses of vaccine before the radiation and then 6 after. Then there was a maintenance treatment afterwards, or there was a matching placebo. The endpoint was the response rate, so seeing what the shrinkage rate was with the vaccine as compared to just radiation. And they had progression-free and overall survival. So the study was designed that there was meant to be about 50 patients, so about 24, 35 in each arm. Unfortunately, the study was negative. So once they randomized about half of the patients, they did the interim analysis and found that there was no difference. In fact, numerically, placebo did a little bit better than the vaccine arm. So I don't think it shows that the brachyury is not a target. Maybe it was a bit of a simplified model. Again, the vaccine to antigen would usually more produce what we call B-cell humoral immunity, so the antibodies might circulate, but we really need lymphocytes to be active, which are the ones that are immune cells that target the cancer cells better. So there's a lot of potential in looking at different immune drugs. Hopefully in combinations, it's just something that we need to do to induce that response and improve the numbers of people that respond to immunotherapy. And there's various combinations that can be used either with biologic therapies like viruses or bacteria, or with chemotherapy, or with other immune drugs. This was one interesting study that was published recently that looked at using checkpoint inhibitor pembrolizumab in combination with the bacteria Clostridium. So this is the bacteria that causes the same class of bacteria that causes gangrene and bad hospital colitis, called severe colitis. Bacteria were modified, attenuated, so that they're not as toxic as the gangrene-causing bacteria. And then they were injected into the tumor tissue because tumor is a low oxygen environment, and these bacteria thrive in low oxygen environment. So basically, these bacteria would then destroy the tumor tissue, cause like abscesses, and then that will release those antigens that the tumors get hidden inside, and that would potentially improve the effectiveness of the checkpoint inhibitors. This was not a Chordoma specific study, so we recruited patients with multiple tumor types, but what's interesting is that out of 4 responses, one of them was Chordoma patient, and they had the response not only in the injected lesion, but also in the adjacent lesions as well, showing what we call possibly abscopal effect. So that means that the immune system that got activated then managed to act in the other sites as well. The patient had a progression-free survival of about 7 months and then got off the trial more because of the side effects. Another type of immunotherapy that holds promise is the cellular therapies. So those are the, you might have heard of CAR T-cell treatments, which is used in hematological malignancies like myeloma, and it's becoming more of a standard treatment for late disease. It's a logistically complex treatment that requires patients' own lymphocytes to be collected with a blood draw and then modified in the lab so that they can be active against the cancer cells, and then they get amplified, they get multiplied, and then they get reinfused in patients to go to the cancer site and treat. The issues apart from the logistics is first finding the right antigen, and in solid tumors they've been a little bit more harder to act because of the immunosuppressive environment in the cell. However, we had some breakthroughs already in the solid tumors, and more specifically in sarcomas, where the FDA in the States has already approved one of these therapies in synovial and myxoid liposarcomas, based on the phase 2 data. Interestingly, on a single arm study, which is not a common occurrence, and the regulatory agencies approve a drug based on a single arm study. But this was again a trial that used an antigen that is intracellular for the synovial sarcoma, which is similar to brachyury. It's a fetal antigen which does not get expressed in the adult cells, but it does get re-expressed in the cancer cells. You can see that the drug sponsor that produced these drugs have a pipeline of various other treatments that use similar technology. Unfortunately, no Chordoma as yet. So I had a look, and there's definitely a study that shows that the brachyury could be a good target for these kind of therapies. It just doesn't seem that at the moment we still have T-cell therapy that's targeting that. That's something certainly to keep an eye on. And then the new generation, new class of drugs, if we want to call it, is the antibody drug conjugate, which again we heard in the previous presentation, which is a combination of cytotoxic and targeted therapies, where the chemotherapy is bound to the monoclonal antibodies and then delivered selectively in the cancer site. There's been a number of therapies that are used in different cancers. Breast cancer specifically, also some hematological malignancies, bladder cancer, and looking at the receptor targets, we know that Chordoma has EGFR receptor overexpressed. That could certainly be a potentially good target for antibody drug therapies in Chordoma. This is the list of the trials that come on the clinicaltrial.gov website with Chordoma specific search. As we see, unfortunately, none of them is recruiting in Australia. Most of them are in the States. A couple of them are in China, one in Europe. And also in the last column, we can also see that most of them are sponsored by institutions or cooperative groups, and that the industry really is not that much still involved in Chordoma trials. We can see that there's a study that looks at pembrolizumab and methotrexate, so that's the chemotherapy in combination with checkpoint inhibitors. There's a couple of targeted drugs, opatinib, pembrolizumab, or palbociclib. The bottom three ones are not Chordoma specific, but they do accept Chordoma patients, which look at the combination of immunotherapies, or chemotherapies and immunotherapies. The number 4, the one in China, is the one that uses antibody drug conjugates with EGFR monoclonal antibody. This is actually a quite promising compound, because it's shown really good results in lung cancers. With EGFR mutated lung cancers in combination with targeted therapies, to be fair, having 100% response rate, but also good response rates in breast and esophageal cancers. It's really interesting to see what the outcome is on the Chordoma study. We do have a couple of studies in Australia that use these drugs for different indications. Just at the end, this is a list of the websites where you can see and find trials recruiting potentially Chordoma patients. On the left, Australian, and on the right, global. And this is a not exhaustive list, and this is a dynamic list. It's something that's worth checking. Something to keep in mind is that the studies may not be chordoma specific, but they still may accept chordoma patients, especially phase 1 studies, and this is something that may not be specifically stated. But any phase 1 unit should know which studies may be open to chordoma patients. So it's worth doing research beyond what's on the websites. So just to summarize, systemic therapy still has a limited role. There's no approved therapies, but there are drugs that we do prescribe. Chemotherapy probably not much role apart from potentially pemetrexed. And pemetrexed is one of the drugs that we can actually prescribe. It's on a general PVS schedule. The other targeted therapies that are used and suggested in the guidelines may have its own challenges in terms of costs and side effects, and certainly has to be weighed carefully. I think immunotherapy is definitely pushing the boundaries there, and that's where I'm hoping we're going to see more results, and certainly this has more potential. And of course, clinical trials is something that is really our main resource to get people on novel therapies. And when I say that, phase 1 trials are probably the most relevant currently for chordoma, especially in Australia. And that's all I have. I'm happy to take any questions. Thank you.